frequently asked questions about syncope. What is syncope? Syncope is a sudden, brief, and transient loss of consciousness caused by cerebral hypoperfusion. What are the different types of syncope? Neurally mediated syncope is the most common type, comprising approximately 45% of cases. It can be vasovagal, situational, or secondary to carotid sinus hypersensitivity. The pathophysiology is complex, consisting of an interaction between autonomic systems paradoxically favoring parasympathetic or vagal tone, which causes bradycardia and hypertension. Cardiac syncope occurs in approximately 20% of syncope presentations. It is most often caused by an arrhythmia, and less often by a structural cardiac abnormality. Patients with cardiac syncope had a twofold increase in mortality over 17 years. The presence of cardiovascular disease predicts a cardiac etiology of syncope with 85% to 94% sensitivity and 64% to 83% specificity. Orthostatic hypertension syncope has an incidence of approximately 10% and is typically characterized by posturally induced hypertension, most often related to impaired increase in systemic vascular resistance. Associated factors include medication effects, volume depletion, acute hemorrhage, and autonomic dysfunction. What is the risk stratification strategy for patients with syncope? The patient is at high risk if any of the criteria are met, and will require hospital admission. Clinical history suggestive of arrhythmic syncope, for example syncope during exercise, palpitations, or syncope without warning or prodrome. Comorbidities. Electrocardiographic history suggestive of rhythmic syncope. Family history of sudden death. Hypertension with systolic blood pressure less than 90. Older age of 50 years and above. Severe structural heart disease, congestive heart failure, or coronary artery disease. Patient is at low risk only if all criteria are met, and will only require outpatient evaluation. Age less than 50 years. No history of cardiovascular disease. Normal electrocardiographic findings. Symptoms consistent with neurally mediated or orthostatic hypertension syncope. Unremarkable cardiovascular findings. What should the clinical history focus on? The history should focus on three key elements. Is the loss of consciousness attributable to syncope? Is there a history of cardiovascular disease? Are there clinical features to suggest a specific cause of syncope? What should the physical examination focus on? The examination should focus on initial vital signs, orthostatic blood pressure measurements, and pulses and carotid brutes, cardiac, pulmonary for evidence of congestive heart failure, abdominal, rectal, and signs of anemia. Any new focal neurologic findings suggest a primary central nervous system lesion. What diagnostic testing should be done? Patients presenting with syncope should have orthostatic a standard 12-lead electrocardiography. Laboratory and imaging studies should be ordered for patients with syncope only if clinically indicated by the history and physical examination. Implantable loop recorders increase diagnostic yield, reduce time to diagnosis, and are cost-effective for suspected cardiac syncope and unexplained syncope. What is the treatment for syncope? Treatment of neurally mediated syncope includes reassurance, education, and physical therapy. In situational syncope, it is important to avoid potential triggers. Physical counterpressure maneuvers such as leg crossing, squatting, and tensing the lower extremities are effective at the onset of prodromal symptoms. Treatment of orthostatic hypertension includes education and lifestyle modifications, such as slowly transitioning from a supine or sitting position to standing and increasing fluid and sodium intake. Contributing medications should be discontinued or decreased, if possible. Other treatment modalities include elevating the head of the bed by 10 degrees, compression stockings or abdominal binders, and counterpressure maneuvers. If these do not mitigate symptoms, midodrine and fludrocortisone are effective treatments. Management of cardiac syncope is directed at the underlying etiology. Options include antiarrhythmic drugs, cardiac pacing, catheter-directed ablation, and, rarely, implantable cardioverter defibrillator placement.
Audio Jungle. Audio Jungle.